So this is part 2 of a 3-part series. Part 1, which provided tips on how to assemble a team, is available on our website for you. And today we'll be working on prioritizing a change idea. Glad to see so many familiar people back, and welcome to the new folks. There will be 5 of us facilitating today's learning session. Myself, Alekia Johnson, and Sangeeta Singh, who are all coaches with the RGP, and Deborah Brown and Zainab Rizvi, who are clinicians with Delirium Implementation expertise. We want you to come away with skills and ideas for engaging people in your organization to gather their perspectives on the change idea. And we want you to feel like you have the know-how to select and define your change idea. We'd like to take a quick poll so we can learn a little bit more about who we've got gathered here today. All right, we can close the poll, Sarah. Have a look at what we've got. So it looks like we've got acute care, hospitals, rehab, complex continuing care, and long-term care represented today. And in terms of roles, we've got frontline managers, a supervisor, executive, director, and a few others. And most of you are from nursing. We've got some OTs and a few others here. Welcome to all of you. Glad to have you. So where do you start with prioritizing a change idea? Step 1 is really engaging people in teams. And in our registration survey, many of you identified that it's really challenging to engage people and that people are resistant to change and tired of change. It's hard to get people to agree on an idea, and it can be really tough to maintain the momentum. So we want to help you with these issues. The first step to prioritizing a change idea is engaging and listening to the front line. The people who do the work know how to change the work. They know it's been tried before and what didn't work and why. And the key to your success is ensuring that the front line feels valued and part of the process right from the very get-go and all throughout the initiative. So let's look at some ways on how we want to engage them. Okay, so you want to use two-way communication mechanisms. You want to engage people and you want to find out things like, what does the current state look like compared to the standard, and why they think there's a gap there between the standard and the current state. So looking for root causes and what they think should change first and why. And it's important to gather this information because you really want to prioritize solutions that are most important to people and that address root causes. So we're going to share a few ideas with you on how to engage the front line that's been used really successfully in hospitals and other healthcare facilities in quality improvement initiatives in Ontario. So idea number 1 is hold a contest and consider a naming contest at the beginning of your initiative. If you can offer a prize, even better. And what this does is it really creates a buzz around the initiative, and it starts engagement early on. And it helps people to feel like they're going to be listened to and part of this change right from the get-go. And when people on the front lines have been involved in naming it, there's also this sense of ownership that comes with it as well. Idea number 2, use a dot survey so people can vote on change ideas. And to do this, there's a picture of it there with the 2 charts. Just list the ideas, give people sticky dots, and let them place their vote on what they think priorities are for them. And so then you'll get a sense of what's important to people or where they want you to focus on the changes. Number 3, comment or suggestion box. Good old-fashioned one. It's anonymous and it usually is very inviting to a wide variety of people. People feel like they can really get something off their chest when they can just tuck a little note into a box. And you can either put the name of the initiative on this box or post one of the questions. So ask something specific that you want people to address. And idea number 4, one of my personal favorites, is the graffiti board. And this is just a large piece of paper with a problem statement at the top. And you're inviting people to put suggestions for how they would address this problem, how they would fix it. And a key point for this one is that you want to pre-populate this blank piece of paper with the ask at the top with 1 or 2 ideas to sort of prime it. There's something funny that happens with a blank piece of paper that's posted. Sometimes it just stays blank because nobody wants to be the first to put something up there. It can be intimidating. But the graffiti board is really your most interactive mechanism. People start reading it and responding, and you get this little dialogue happening. So it's a really nice mechanism. Now, whichever mechanism you choose, you want to make sure that you're communicating the results back again. This is that two-way part. So people want to know what happened with the opinions that they gave you. They want to know that the suggestion box is not a black hole where good ideas go to die. They want to know what did you do with it? What did you think about it? What's happening because of it? So make sure you build your feedback into your communication plan. So however you're planning to communicate about the initiative in general, regularly with newsletters, with huddles, with posters, whatever you're doing to communicate in general, make sure you're building the feedback from these mechanisms where you're gathering opinions so people know what's happening with them. If you don't, people feel like they're not being heard, like their opinions don't matter. And lastly, one important tip to share with you around the two-way communication mechanism, if you're not getting feedback, you're not using the right mechanism. And I've seen this at play. So for example, Hospital A decided to put a suggestion box out in their inpatient unit. And this thing was full, like right from the get-go and ongoing throughout the initiative. It was very successful for them. Hospital B saw this and thought, oh, wow, suggestion boxes really work in the hospital. We'll put one in our ED where we're piloting something. And that suggestion box stayed completely empty for an entire week. And when the implementation lead asked around, staff said, oh, we're too busy. We don't have time to put anything in there. So they switched tactics and they put up a graffiti board in the bathroom and they primed the pump. They put a few ideas that they had already, and that thing was filled. It started filling up in the first day and within the ongoing days. So that mechanism worked really well for them. And the moral of the story again is if your mechanism doesn't work, just change it, just try something else to engage people. So those are a few ideas that we've had and wanted to share with you, but we'd also like to hear what you've done. What are, somebody saying, put it in the bathroom. That's what was actually done in the hospital. That was pre-COVID. And it was a big enough space for it to go. It wasn't above a toilet. But yes, there could be some issues with putting it in a bathroom. But it was the one place where staff went and they could feel safe about sharing their thoughts without people seeing who was writing what. If anybody has comments, questions, other suggestions, please feel free to put them in the chat box or raise your hand. Let's hear from you folks. I know there's a lot of experts here in the room. Focus group. Yeah, that's a good one. Somebody's saying huddles. Huddles are great too. Huddles are great for both collecting information and sending feedback back, right? It's a loop of communication, the huddle. You can give and you can get in the huddle. Interviews, for sure. Surveys, absolutely. Someone has joined late, so the 4 things that we talked about here to gather opinions was a suggestion box, a dot survey where people place a vote on the ideas, a graffiti board where you ask a question, ask for advice, and a contest. And suggestion was for a naming contest for people to name the initiative. Using an app in a virtual meeting that allows people to give feedback and comments without their name is helpful. Padlet or Slido, etc. Yeah, that's a good one too. So it's great to sort of think about and build on the ideas that you've tried. And like I said, if you've tried something and it hasn't been that successful, it's not that it's a bad idea. It just might be the wrong one for the wrong place or at the wrong time. So keep trying and make sure that you're feeding back the what's coming into you so that people feel engaged and that they're being listened to, that their opinions are mattering. So we'll turn it on to Alekia now for step number 2.
Thanks, Wendy, and thanks everyone for your contributions. So to those who are just joining the line, we just went through step 1, which was engaging your people. And now step 2 is referring to the list of change ideas in the Delirium Practical Implementation Guide. So you may have already seen that Ontario Health released a quality standard in March of this year. And in that standard, there were 7 quality statements, and you can see those here displayed on the screen. And so what we did at the RGP was that we took those statements and we broke them down into more manageable, implementable chunks. And we're calling those chunks or interventions change ideas. So on the right, you will see a screenshot of the practical implementation guide. And I'm going to ask Sarah, if you haven't already, Sarah, if you don't mind giving everybody the link to this implementation guide. So I thought it would be good just to crack open this guide and show you the change ideas, just in case some of you have not had the chance to really sit down and peruse through this. Great, so hopefully you can see my screen now. So I'm on page 6 of the guide here, and you can see that it says table 2, change ideas, and we've got each of the 7 quality statements here, and under each is 1 or more change ideas for you. So we've already compiled these are evidence-based. And so just to walk through some examples. So under quality statement number 2, interventions to prevent delirium, we've got a whole bunch of ideas like implementing a standardized order set, and you can see that we've linked to an order set there, so you don't have to create one. There is an opportunity as well to implement a prevention toolkit for patients. That's linked there. And then there's a whole set of other change ideas, like if you could do daily socializing as your focus, and there are a couple of toolkits there. There's more around physical activity, sleep promotion, staying hydrated, ensuring proper nutrition, and so on. And I also wanted to highlight under quality statement number 3, we have 1 change idea there, which is implementing a delirium screening tool. And we have actually compiled a table with all of the top screening tools compared, because we often get that question, what tool should I use? What's the best tool? So we've got a few different metrics there, and you can use that to compare and choose what works best for your setting. So we hope that this is helpful for you. If you haven't had a chance, this is a good starting point to get a sense of all the options you have for implementation. And like Wendy was saying earlier, you could take a few of these from this list or the full list and do something like a DOT survey with folks in your organization, or use something like a Menti poll if you're doing a virtual meeting. You could also just have a conversation and unpack, which ideas on this list are most relevant. Where do people feel like they want to make a change? So this is just an overview, but please take your time in combing this through if you haven't already. And you can see here the last statement here is around transitions. So we wanted to pause here for a second and give you an opportunity to share. We wanted to, at our first session, we had quite a bit of content, and we want to take more time this time to hear from you, hear your ideas and your questions. So if you've had a chance to look through the change ideas, what ideas have you used so far? And what do you plan to implement this time? So we wanted to open up the floor to all of you to hear your thoughts. So you can enter things in the chat box, or you can also raise your hand and Sarah will unmute you so you can actually speak to the rest of the group. If you want to refresh yourself in terms of the list of ideas, feel free to click on the link that Sarah has provided in the chat box, and you can look starting from page 6 at all the different ideas.
I see Sylvie's got her hand up there, and it looks like you're unmuted now, Sylvie.
Okay. In 2013, we implemented a new policy on delirium and early on screening and all that. By the time it was all done, it was officially circulated in 2015. I work in a hospital setting and I work with all the long-term care units. So we said that anybody who's admitted 70 years old and older should be screened for delirium anyway. We developed the policy, went through all the channels, and we kind of implemented, did short blitz. I did short blitz with the managers and the resource nurse on each of the units. But now we're revising that policy because it's not working. People are not being screened when they're admitted. So it is a problem. And I mean, you know that delirium is very frequent during hospitalization. So I use blitz. I used to go in the units and do blitz about the policy, how we use the tool to screen, what it looks on the electronic chart and all that. The reason why they don't do it anymore, they don't screen, I don't know. That's why I'm trying to figure out. So I use blitz. I face-to-face, physically being there and, you know, going on the unit and saying, okay, do you have people available? Then take those people, bring them in the little employee room or wherever the employee lounge and do a little blitz. I don't know what's going to work now because we have a lot of a shortage of staff.
Right. Thank you. Thanks, Sylvie, for chiming in there with your experience. It sounds like it was quite successful with your initial round of strategies, and definitely the key with sustainability is that it needs that ongoing effort, right? And what worked in one season might not work in another season. And of course, COVID really has changed that a lot. But thank you for sharing your experiences. I'm going to ask Wendy if you can let me know what's in the chat box there, if there are any comments or questions.
Yeah, there's a couple of comments. So somebody's created a patient and family information handout about delirium and how to prevent and identify it. And another person has a delirium care intervention protocol.
Wonderful, thank you. And if you're able to share those resources, we can certainly distribute those amongst the audience here today after this webinar as well. So please do send us a note if you'd like to do that.
There's another comment that just came in, was implementing the hospital elder life program HELP, which was going well, but COVID redeployed help staff to other roles and volunteers not permitted back yet. And question, Sylvie noted, why did they stop? Screening is important. What is the impact of screening or not screening for the staff?
Absolutely, all very insightful and important questions as you try to dive back into sustainability for your efforts. Okay. So if there are any more comments or questions, please keep them coming, and we will have another opportunity again to get your feedback and thoughts. Okay. So step 3. So now that you've had an opportunity, let's say, to look through that list of change ideas, and you've engaged your staff and leaders, and you've, let's say, selected a change idea. The next step then is to really flesh out the specifics. And if you're having another round, like a second go at a change idea, it's still good to revisit this, because maybe there's some details that need to be switched around, like Sylvie was just saying. What worked before maybe needs a different spin on it. And so we've created for you a worksheet called the 5 W's worksheet. And it's got, of course, the why, the what, the where, the when, and the who. So the purpose of this sheet is just it can be used in multiple ways. It can be used as a discussion tool. It can be used as a planning tool. It really is, it's meant to aid you in your thinking and your engagement, further engagement with point of care teams and leaders. So we're going to walk through a bit of an example here. And actually, Sarah, it would be great if you haven't done so already to paste a link to that worksheet in the chat. All of you should have received also a copy of the worksheet in your email as well. So for today, we're going to walk through an example of how that sheet can be filled out using the example of screening. And you can see, we've picked that it's a quality statement and it's a change idea directly from the guide. Okay, so the first row there in your worksheet is the why. So why have you selected this specific change idea to work on? And so we talked a little bit about this in the first session, just about having the key messages for your leaders, key messages for your point of care teams, and also the rationale for why this and why now. And this really becomes your North Star as you continue to persevere in implementing this particular change idea. And we have an example here of some messages that we might want to include. The next row is the what. And so this is where you really want to spend some time thinking about some of the details. So the first question is, what is the outcome indicator you want to change? So in our example of screening, we took a look at the quality standard. Pages 40 to 44 actually have a whole list of indicators, so you don't have to make anything up from scratch. It's all there for the choosing. So in our example, we're looking at changing the percent of older adults 65 plus who presented to hospital and who are screened for delirium. The second question is, what is the specific action that will influence that outcome indicator? So of course, the obvious answer here is daily screening for delirium using a standard assessment tool. And so this piece is important because sometimes the actions or the ideas that we choose don't necessarily link to the indicator that we're aiming for. So this can be a good conversation tool as you're working with your core team. And the next question is, what process measures will help you track changes in your action? So in this case, we've said we're going to do a small and quick chart audit to look at the change in screening before our efforts and after our efforts. So the key here was we wanted to be simple, as straightforward as possible, and making the best use of our resources. And then the last question for this section is, what is not in scope for this change project? So this is another critical question because, as all of you know, you've got tons of resource constraints, multiple priorities, and so if you don't have a bit of a think about the scope, sometimes it can turn into this feeling of you're boiling the ocean, right? So, and you want everybody who you're working with and who's involved in this work to be aware of what the actual scope is. So in this example, we've said we're going to focus on screening alone for now, and that we will tackle other aspects of delirium care at a future time. Now, this is just an example. Of course, as we've discussed, as I think someone said already on the line, sometimes screening alone is not, effective, because staff want to know what's happening with that. So maybe for your change idea and your project, you might combine screening with another change idea. So this is just an example. The next row is the where. So this is a simple one. Where will you actually implement? So you might pick 1 unit or 3 units, and maybe you pick them because they're working on related initiatives. That's what we've done here in this example. The when. So when will the action take place? In our example, we've said we want to screen within 2 hours of admission and once a day. And then the next question is, how long will it take to implement this specific action? So we've said 6 months, and then we'll decide next steps. And the reason this piece here is important is because, like Sylvie was saying, we want to think about sustainability as well. So how long will we do, for example, the blitzes, let's say, that Sylvie did? How long does that go on, and then what happens? So it's kind of fleshing out a bit of a rough timeline in your mind. And then the last row here is the who. So we spoke quite a bit about this in our first session, and this provides you a list of all the different people who you want to engage in some format or another, perhaps using some of the tips and ideas that Wendy shared earlier, as well as some of you on the line. And one of the key things here is the first question: who will need to do the actual change idea? So the screening in our case. And we've listed nurses. However, of course, it can be anyone in the interprofessional team, but it's important to specify who exactly is going to do it or take leadership on it. Because as we know, there's a saying that goes, if it's everyone's job, right, it's no one's job. So we encourage you to be as specific as you possibly can. And then think about who are your allies, who can advise you, who can support, in this case, nurses to do the screening. So we have, listed delirium champions or geriatric consultants, clinical resource leads, and so on. So this is an overview of the 5 W's worksheet. We will share this completed worksheet with the example with you after this session. So you have that for reference as well. And so we wanted to take another pause here just to see your reaction. So which of the 5 W's was new for you, and how might it help you plan moving forward? So feel free to raise your hand or enter something in the chat box.
Well, it looks like we missed a raised hand from before, and somebody's put something in the chat box responding to Sylvie. Screening only works if staff truly see evidence of why they are screening. Do they understand the purpose? Who is following up with the CAM is suggestive of, if the CAM is suggestive of a possible delirium. Sounds pretty basic, but I've seen it be the main reason why screening is not successful. An excellent comment.
That's great, and that really taps into the why, right? So if we're not clear about the why, and if our teams don't know the why, that will influence whether they actually participate in the change. So that's great. Any other comments or thoughts?
Another comment has come in, same, and a block is physician buy and follow through.
Great, any more questions, comments, reactions? And we'll be talking about, actually in our 3rd session, about those barriers and creating an action plan to address challenges like physician buy-in as well.
There's another comment. I find it helpful to know ahead of time what might be potential barriers and facilitators to implementation.
Absolutely. Definitely. And that's information that you can gather using those engagement strategies, even at this stage as you're selecting your idea.
Another comment about doctors don't really want to go through reasons why delirium might happen, so it's a barrier. And it's interesting too, as leaders in implementation, we often have some evidence or some intuition as to what's happening in terms of barriers. But to go back to the engagement piece, the more you can really ask people to put their opinions somewhere, anywhere, whatever mechanism you're going to use, to just validate and hear a wide variety of perspectives is really helpful.
Okay, keep those comments coming. And I'm now going to turn it over to Sangeeta to lead us in our implementation expert panel.
Thanks so much, Alekia. I'll ask Deb and Zainab to take their video off as well. Hello, everyone. It is such a pleasure to have Deb and Zainab join us. Both of us are implementation experts, and they are here to share their learning, their experience and expertise in implementing delirium prevention and management protocols in their organizations. Some wonderful comments there just before we get started with our Q&A. And I found it Sylvia's comment about making sure that we make the staff aware of about the value of their work, why we are asking them to do what they're doing. It kind of touches on some of the conversation we had in our first session as well, really recognizing that people need to see the meaning behind the work they are doing in order for them to engage and have value, to recognize that their work is having a positive impact. We got a lot of questions, Deb and Zainab, from the registrants for this session. And a number of them were talking about, and some of the participants today touched on that as well, this whole issue around, the big elephant in the room around implementation right now is COVID and the impact it has had on staffing, on resources, on just how much of a demand has been placed on the healthcare system. So, launching new initiatives at any time is a challenge because the healthcare environment is so busy. But I thought we'd start by just checking in with you to see what impact the pandemic had on your delirium prevention and management work. And Zainab, since you're unmuted, why don't we start with you?
Sure. I think the important thing here is there's never a good time. We have to always keep that into consideration. As we know, all our hospitals are always at capacity at any given time, especially winter. So there'll never be a good time. There were a lot of challenges, and the delirium screening did take a bit of a dip, and we did have challenges. There's lots of reasons, right? We had people coming in who were otherwise not would have been doing well in the nursing home and retirement home, but they got deconditioned, and now they had depression and deconditioning, families not coming in. People who would typically be wandering were not allowed to wander. I don't like using that term, but you know what I mean, is walking through the halls. They're not allowed to do that anymore. So now they're stuck in their rooms. We were short-staffed. We didn't have family supports. You're not allowed to take the patients by the nursing station. PPE, you look like aliens going in, to these patients. And the biggest thing for me, honestly, was people who were being touched by a bare hand were not being touched by a bare hand anymore. It was all gloved hands for months and months. So any opportunity I had, if they weren't on contact precautions, I was going in and touching them with their hands. So we were affected. A lot of, we just had to keep reiterating, let's try to prevent the delirium. Sometimes we can't, but simple things that we can continue to do, even if they're on precautions or in a COVID unit, you still need to do the basic stuff. So keep screening, lights on, blinds up during the day, keep the TV on, keep socially interacting, even if it means through the door. So there were a lot of stumbling blocks, but we just had to keep reminding people that it's business as usual. It's just that because we have an established delirium team, so it's a little bit different, but it did take a hit. I couldn't get help, like somebody had mentioned help. Relied on my help colleagues, the volunteers, pet therapy, all of this stuff went by the wayside. And we ended up doing a lot of talking on the phone with the family. I felt like part of my job was also giving them the attention, the family, the attention that they needed in person. Now you're doing it on the phone. So I was on the phone much longer than normal, talking to family about how to manage the patients. And sometimes I would get them to send me emails of photos so I could print them out, put them in a plastic sleeve and give them to the patients, right? So they had something. We had iPads on the units. We would take those in for FaceTime calls. So we had to, and being an OT is helpful because we think outside the box a little bit. So it was helpful to kind of, okay, now we've got this problem. How are we going to go around it? But still the prevention is so important because as we know, prevention and management is the same thing for a lot of these patients, but just, it had to be business as usual. When you're starting something up, it's a little bit trickier because, a lot of initiatives in the hospital went by the wayside, but this was one that couldn't because seniors coming in, sometimes they had no other symptoms except that they were delirious. And when you checked them, they had COVID, right? So it was a tricky time. Things have gotten a little bit better, but there'll never be a good time to implement stuff. There's always going to be something. This was a little bit of a big thing, I would say, but there's always going to be something, but this is really, really important, especially because of our aging, society.
Thanks so much, Zainab. And thank you for acknowledging just how hard it is at any time. And there's no good time, but we still have to get it started. Deb, how about you?
Well, wonderful comments by Zainab. Wonderful comments. So before I mention a couple of other things that are associated, I do want to pick up on her comment about the hand touch. I think this is such an important piece, especially with communicating with patients with delirium. If used appropriately, a hand touch is a strong a vehicle for communicating intent, like facial expressions as well. It often can be used so successfully to set a tone for engagements with patients who may be having difficulty with verbal, etc. But the nonverbal and the hand touch really can be very effective in setting a tone, and your interaction with patients often goes much smoother than if you come in with a very different sort of approach to communication. So I just wanted to recognize and thank you for talking about the hand touch. Also, with the COVID, we talked about staff shortages. We talked about staff having to wear PPE, which in a communication piece has huge impact with communication piece. Sorry about that. Because you have masks, you have shields, and you have patients who can't hear and see well, and it has a huge impact. And of course, the staff as well, to prevent risk of exposure. We're going into the rooms less often than what they normally would be, with patients, leaving them at more risk for isolation. And of course, we weren't allowing the families in. And this, I think, had an impact on patients. And again, using iPads for direct connection, etc., are good opportunities. But the cumulative effect of a lot of these things can be serious for our older patients at risk for delirium. So I guess, I think that was generally all I had to say in combination with Zainab's comments. And I also think, though, there was something else happening. There is something else happening, and I think it's diminishing now. But when we were in the height of COVID, the day-to-day frame of mind of everyone was different than normal. You were kind of like a crisis mode all the time. You didn't know from day to day what was going to happen. And so that affects how you are, right? It affects how you are and how you are with patients, how you are with your coworkers as well. It kind of wipes the slate sometimes and puts you in a different mode. And I think that affects how effective you can be in certain areas. Thanks.
Thank you. And thank you. I really appreciate both of you being so honest about the experience that you and your colleagues have had. And I just find it so incredible that we have the group that we have here today with us, who are, working at implementation with all the challenges that all of us have faced, but more so the people on the front line. So I really honor that. A number of the groups, and it kind of reminded me a little bit about the topic that we discussed in our last session, which was developing that elevator pitch, a quick, effective message to capture the attention of the audience that you are wanting to reach out to. And we had talked about that in our last session as well, engaging staff, talking to them. And Zainab, you sort of alluded to that when you were talking about some of the challenges that you faced during the pandemic around getting to the people, and just reiterating the importance of continuing with these practices. And definitely the fact that both of you are coming from organizations that have embedded processes for delirium prevention in place, that gives you a bit of momentum. But for organizations that are just starting out now, what sort of change ideas would you suggest to them? We have quite a few colleagues in the group today who have talked about that challenge of engaging physicians, for example. What would be some suggestions? What would be a good place to start where you could sort of get a bit of impact and get some engagement? Who would like to go first?
I can start off. I can, and I guess I speak a little bit from our own experience at the hospital. I think that given that we have the times that we have presently, if you can partner with other initiatives that have similar outcomes or similar goals, then I think it's a good thing to do. And that's what we're trying to do as well, because we've got some inroads in screening and care protocols, but we need to move beyond that, and we need to move beyond in prevention strategies as well. But there are other outcomes that are associated with best practice that also can be married to delirium prevention and delirium care. So, if you've got a movement, if you have a movement going on with fall prevention or pressure injury prevention, a lot of those risk factors that precipitate safety incidents with staff, if you've got a movement to move some of those things, join that, because it makes a little better sense for the staff when everything comes down to sort of a coagulated approach. So joining other linked initiatives to make it easier on the front line, excuse me, I think will be helpful. And I really do feel good delirium prevention care will provide positive outcomes in many best practices, not just delirium. So I would suggest joining forces with other movements that are going on. And if there are no other movements, start one. And tell your story. Tell your prevention story in a way that it's positive for many outcomes, and try to get some measurements. So I can talk a lot, so I'll stop right now.
Thanks so much, Deb. Zainab?
I think that's a great idea. For sure, all of what Deb was saying. I think it's really important to let people know what's in it for them. What you're doing or you're wanting to implement, how is that going to affect my day-to-day?
Yes.
And so I'll give an example. Implementing the CAM is huge, right? So we do the CAM, and that was our first implementation, is CAM to be done once a shift and PRN. So if your patient's fine in the morning, you did your CAM, but by afternoon, there's something weird going on, do it again. But the good thing, and this has come up many times, and that's why I want to say it, is that the buy-in for them was, if I do the CAMs properly, and which is another issue in itself, 2 positive CAMs in 48 hours, and we, as the Delirium team, get a ding, ding, ding email saying this is potential delirium going on. So the buy-in for them was, oh, if I do it and my patient has delirium or potentially, then the Delirium team is going to check in. So there's something that's going to be done about it. I know that's been a theme that keeps coming up.
Yeah.
And so that was, and then the important part is that we show up, right?
Yes.
And say, okay, what's going on? Let's see. Let me go through. Let me figure out. Let's see what we can do. So that was for the physicians, because now I'm taking some pressure off them because they don't have the time to do the deep dive that I'm able to do. I'm, helping strategize with the staff. So whether it's allied or nursing, although I might give them some work in the sense that, okay, let's toilet this person Q3 hours. In the long run, this person's not going to be climbing. So
Yes.
that buy-in, and it doesn't happen overnight. And that's one thing I think everyone needs to know. Like, we are established once again. Now people recognize me. When I come on the unit, they're like, oh, thank God. Like, it's the nicest feeling in that sense where you're like, you're appreciated, but they recognize that, okay, we need help. We did the CAMs, you came, there was an outcome to me doing this work. So that I think is really important. And I think it's a good place to start, is because awareness of delirium is super important. We're doing the CAMs, we're seeing these flags come up. These people are coming up as delirious. Now we can address the problem. Step 2.
Yeah.
Great. Thank you. I think, Deb, you really spoke to that idea of not reinventing the wheel. So really being strategic to say where we can find allies within the organizations with initiatives that are already ongoing, and sort of latch onto that so that our work gains momentum. And then some of the points you spoke to kind of tapped into what Sylvia was talking about, people being able to see the outcome of their work.
Yep.
And that positive CAM that they've done will get them the help. Sylvie talked about doing the blitzes, and I think that's real power when people actually have a face-to-face interaction with the people that they see as support. Mm-hmm. So building those relationships as well. Deb?
Sanjita, sorry, I can just chime in. I just wanted to say, add a comment, is that it always never ceases to amaze me how impactful it is to do what Zainab was just saying. To when staff ask for help, if you go, and even if you only help them with a couple of things, maybe you've discovered why potentially the patient's delirious. It never ceases to amaze me how long they remember that. And it may be something simple that you found that the patient was constipated or they had urinary retention. They remember that you came and helped them with that, and they apply that to the next cases. We sort of take that for granted, but they really do remember a lot of the problems that you helped to solve. And they don't have to be like a multitude of problems, but they remember it, and so it's really helpful for them.
Even with physicians, like it will be, I will walk by a physician, 10 minutes later, I get a direct referral from him because seeing me reminded him, oh yeah, she helped me last time. So your presence in the hospital, being on the units, so vital. I don't sit in my office. I will be on units all the time because you are a visual reminder of what you can offer.
Yeah. This is such a perfect segue to the other question that I wanted to ask both of you, because for a lot of implementers, if they are the sole person working in the organization on their initiative, it can be a really lonely experience and you feel that you're by yourself. What would be your tips and suggestions to our members in the group today for things that they can do for themselves? It could be change management, communication. What would be tips and strategies that you would suggest?
Zainab, do you want to start or?
Sure. So I'm the lone wolf at CVH. And I'll tell you, although I am the lone wolf that goes unit to unit, I have friends everywhere. So building that rapport with managers, educators, staff, nurses. I've got great rapport. And so if there's one thing I've learned on this job is people skills and the tact of getting people to do what you want them to do in a very nice way, in a very tactful way, where you're working together, obviously, but I'm a third person coming on a unit saying, I need you to do this for this patient. So you learn a lot of tact on the way, and you learn to build rapport and relationships. There were some physicians that wanted nothing to do with me. And, once I proved myself, it was, more and more, I was getting more and more good feedback. The other thing I would say is part of my role is also education. So in the moment education with staff, if I see externs, I grab them. If I see students, I ask the educator, can I grab them for a half an hour? Because I'd like to give, and I think somebody said that, is that the CAM, right in the beginning, they said, the CAMs kind of fizzled out because of whatever reason. That's always going to be an issue in the hospital because we have change, we have turnover, and especially through COVID. Oh my goodness, like how many nurses left and how many nurses came and all this stuff. So you're forever doing capacity building. So part of my role, so this is how we do it. Part of my role is capacity building in the hospital, and part of my role is clinical consults on difficult deliriums. I should work myself out of a job, right, where people know how to do delirium prevention and management. So simple delirium, I shouldn't be called for because you should be able to manage that. But really it's the difficult consults that I go for. And also capacity building education is forever. I think if we say, we're going to implement education and be done with it, it's not going to work.
Yeah.
Forever doing. So I'll Q4, we go and do audits and make sure the CAMs are done properly, and that we can do prevention and management again, it's like a broken record sometimes. But really, I'm kind of autonomous, where if I see that the CAMs are not coming up in a unit a lot, I'll go and say, can I step in a huddle and do a little blitz, like somebody like that lady was saying is doing that blitz, because I keep an eye on the 10 units. What's happening? Where is it happening? Why am I getting direct referrals, but I'm not getting the CAMs to follow, that kind of thing. So super important.
Yeah, that's great. Thank you so much. And Alekia just chimed in and said, that's so key. Education is forever. And I was actually just thinking on that whole idea of capacity building and culture change, it takes time.
It does take time.
And it's an ongoing process. So this was my learning as an implementer. Be kind to yourself as well, because sometimes it can feel like I just talked about this last week, you know.
And you might get some eye rolls. Like, I'm not even lying, but we did get some eye rolls in the beginning. And it was like, and when you crack a nut where you're like, oh my God, I got through, they understand what's going on. It was so fulfilling. So now we're much better off, but sometimes it's like beating your head against the wall, but it's the initial stages.
Yes.
Wonderful. Thank you. It's Deb.
And a comment I'd like to add is that thinking of lone wolf strategies as well. I agree. I think, being there with the staff, highlighting some of the things that need to be done, but are important, and building that sort of that collegiality and that social power with the staff is important. But one of the things I always try to do is, if I'm asking staff to do something difficult, and I know if they're not rolling the eyes, they are rolling them inside. I may not see it, but I will try my best to help out.
Yes.
Right.
And I'll say, you know what? I know it's hard. I know it's going to be difficult, but give me a page or give me a call, or let's organize a time and I'll help. Even if it's getting up to the bathroom or something not glamorous, but really important. And I found that helps create a great deal of empowerment as well, and respect, because we're not afraid to get in and help.
Yeah.
And then they'll remember that, and so they respect you anyway.
Yeah. No, I love that idea of authenticity, and both of you, I think, are alluding to the fact that that's a gift you get back. It's hard work, but then there's personal growth and building of skills that you never anticipated. I could keep talking to you, but I'm very mindful of the time. Thank you so much for your wisdom. I just want to take us, Jennifer's asking about, to all the panelists, what are your thoughts about Delirium champion models? And I think that's a great idea to take into our networking groups maybe. So we had one following the first session. And Jennifer, we really hope you will consider joining us for this one. People shared their experiences of Delirium implementation. We shared resources with each other, which we then sent out to the whole group. We did some troubleshooting. We thought it was a really excellent session, and I think the people who participated enjoyed it as well. So do consider joining us for the next one. I realize time is at a premium right now, but we'll hope to see you there. Finally, before you go, subscribe to our YouTube channel. And if you could please fill out our feedback survey, that would be so helpful. We do value your input and are guided by the feedback you give us in developing the content. Zainab and Deb, thank you again so much for joining us today, and to all of the participants for taking time out of your busy day to join us for the second session. And we'll be looking forward to seeing all of you for our third session, which will be focusing on building your action plan. Thanks, everyone. Have a wonderful day.
Thank you.